Dr. Anil Kapoor, who is a mix of science, art, and philosophy, if I may say, and very beautifully, he had deliberated on few of the concepts, which I would want him to tell a larger audience. One concept was the karma theory, that what goes in should come back to you, and how from the mother to the baby and generation to generation, the hyperglycemia and the programming is transmitted. The second he always mentions is, this is your chance. Nature has thrown a spotlight on few of the women out there in the population who have taken the stress test in pregnancy and failed and declared to be cases of hyperglycemia and pregnancy. So keep a watch on them forever and forever. And lastly, the linkages. GDM today is NCD tomorrow. All of these concepts, which were really remote to the OBGYNs, are now the mainstream of our own thought processes. And I really want the expert in Dr. Anil Kapoor to elaborate more on these very issues. Anilji.
First of all, greetings to all of you on the World Diabetes Day. The issue that Dr. Hema Divakar mentioned about the linkage with karma. Basically, if you look at genetics and epigenetics, epigenetics is nothing but karma. It is how we live our life has an impact on how the genes get programmed. And that's an important concept for us to understand, that philosophy links with science. And it is the karma of our great grandparents, parents, that actually determine who we are and who we become. There's a saying amongst the indigenous populations that any action you do has consequences for 7 generations. And the indigenous people were are actually quite aware of these issues. And in the similar vein, it is important for us to understand that what the mother eats, what the mother's health is, has consequences in fetal programming and in developmental origins of health and disease. And therefore, it is the karma of the parents that impact the child and the future generations. And so that's how I try to link karma with epigenetics in a way. The other issue that you mentioned about the spotlight. So the thing is that in many countries, and particularly our country, women hardly ever get to access healthcare. Pregnancy is one time that, fortunately now, I would say that 80 to 85% of women in India are getting access to a health system. And it's a huge opportunity for ensuring that we are able to test these women for the health issues that they may have. And one of the key issues is, of course, hyperglycemia in pregnancy. So the issue is that having diagnosed hyperglycemia in pregnancy is one part of the story. For me, 2/3 of the job is subsequent to the diagnosis of hyperglycemia in pregnancy. And so what I say is that nature has put a spotlight on this woman. She has been identified as somebody who is at very high risk. And unfortunately, we let her walk away from the spotlight after the pregnancy is over. We do nothing to follow them up. We do nothing to follow up their offsprings. And this is a huge opportunity for addressing prevention. I'd like to, Hemaji, add a third dimension to this spotlighting.
Yeah.
That often we have found in studies that we talk about family history of diabetes as one of the risk factors for gestational diabetes. But we have realized that the linkage is much more with the mother. So in one of the studies that one of the PhD students did, and Dr. Seshaya was part of that, is we found that in Chennai, this study showed that whenever we talked about family history of diabetes, we found that despite the fact that less mothers had been tested for diabetes, more fathers of these women had been tested, but the linkage with the mother's history of diabetes was 3 times higher than the linkage to the father's history of diabetes. So I would like to add a third dimension, that if a woman is diagnosed with gestational diabetes, please make sure that you tell her to get her mother tested. Maybe she would discover an undetected diabetes because of the daughter's gestational diabetes. So that's another dimension that we need to look at. And therefore, keeping the spotlight on this woman, the index case of gestational diabetes becomes very, very important. We should not let these women walk away. It is a bridge that provides us, and in that context, I always talk about how can we do this follow-up. It is very difficult that after the pregnancy, the woman is not diabetic, she is not pregnant, so she is not going to the health system. No, she is going to the health system. She goes there with a baby for the vaccination program, for the Well Baby Clinic. And it is how we can provide that link. So I often talk with my obstetrician colleagues that Indian women put a bindi on their forehead, take the bindi of the mother's from the mother's forehead and put it on the child's card to make sure that that child is then identified as a offspring of a mother with high risk. And so every time the child is brought in for the vaccination program, there is an opportunity to talk not only about the health of the child, but also the health of the mother. And the nurse or whoever paramedic is there could weigh this woman, could talk 5 minutes extra to her about why it is important for her to lose the weight she has gained during pregnancy, why it is important for her to eat healthy, why it is important for her to breastfeed the child, not only for the child's sake, but for her own sake. And the longer you breastfeed, the lower is the risk of developing diabetes in women who have gestational diabetes. And these are things that have been shown scientifically right, that the longer breastfeeding is, the lower is the risk of developing type 2 diabetes in the mother for a woman who has had gestational diabetes. So these are two important things that I would like to focus attention on.
One last short message, like how Muralidhar gave to all the women in the country. I want a message from your end to the government and the policymakers. What is the next best thing they should do?
So I would say that my message is to all obstetricians and to all public health system that having identified a woman at risk during pregnancy, and it is not just gestational diabetes, it is women who deliver preterm births, women who have preeclampsia or any other pregnancy complication. Let us start a new transformation of health in terms of following this mother and the offspring and creating databases to identify future generations that might be at high risk, so that we can do preventive actions and target these children who are born to women with high risk of complications in pregnancy as really somebody that needs preventive care and greater attention, so that we can reduce the risk of NCDs developing in these offsprings.
Excellent. Thank you, Anilji, for being present here and your precious time as well. Because I feel that all OBGYNs, the large chunk of their practice, it's obstetrics. And then the next large bracket comes perimenopausal, when they have menstrual issues, hysterectomy, and things like that. But during this gap in their journey, every year we have enough and more obstetric cases who have hypertensive disorders and hyperglycemia. If all those come for an annual checkup, that is a continuum of care and the enhancement of the practice as well. under the bracket of well women healthcare, because we need to see them, we need to have the preventive care, and we need to carry on the mission of doing our best at the earliest. So with this, I think Dr.
Himaji, I
Kasturi,
just wanted to add
yeah,
one more thing. We
Ji,
are only talking about type 2 diabetes and risk, but the risk for cardiovascular diseases in women who have
huge,
had gestational diabetes is extremely high.
huge.
And we are going to witness a massive increase in cardiovascular diseases amongst women uh, 10 years from now because of the fact that we are not paying attention to women's health during pregnancy.
Yeah, because these issues of hypertension, diabetes, etc., somewhat were seemingly disconnected to the obstetrician's purview, but now we are like well into the thick of it, and I think we really need to pay serious attention to this continuum. I think Dr. Kasturi Dodimat was, yeah.
We should change over from being obstetrics and gynecologists to being women's health experts.
Yes, because that's why I said that well women healthcare. Because just imagine the volumes that will be added to the practice every year as a separate vertical segment of checking out their wellness, which gives enough opportunities not only for these, but also early detection of cancer and routine other tests that we have to institute in these women. So that is something that we will figure out a way how to propagate that. So thank you very much once again, Anilji.